In this case, we present an elderly female patient with symptomatic primary osteoarthritis of the distal interphalangeal (DIP) joint of the index finger. Due to persistent pain, deformity, and functional limitation, surgical treatment was indicated in the form of DIP joint arthrodesis. My preferred approach is a dorsal H-shaped incision. The skin and extensor tendon are incised together in a single layer directly over the joint, avoiding subcutaneous dissection. This technique helps preserve the vascularity of the skin flaps, minimizes the risk of skin necrosis, and simplifies closure at the end of the procedure. Once the incision has been completed, passive flexion of the DIP joint helps progressively open the surgical field. Depending on the exposure required, the proximal limbs of the H-incision can be extended and released as needed. We then proceed with capsuloligamentous release. Using the scalpel directed dorsally, the collateral ligaments are carefully released from the joint line proximally, allowing the joint to gradually open and providing excellent visualization of the articular surfaces. Meticulous hemostasis is maintained throughout the procedure to ensure a clear operative field. After adequate exposure, preparation of the middle phalanx is performed first. The condyles are resected carefully, aiming to obtain a flat and uniform surface while avoiding residual irregularities. The cut is generally made perpendicular to the longitudinal axis of the finger, with slight adjustments according to the desired final alignment and functional position. For surgeons with less experience, or in challenging anatomy, fluoroscopy can be used to confirm both the level and orientation of the resection. Attention is then turned to the base of the distal phalanx. This step is often slightly more demanding due to the small size of the distal fragment and the anatomy of the ungual phalanx. Dorsal osteophytes are first removed, usually with a small rongeur, and the final preparation is completed using a microsagittal saw, small osteotome, or scalpel depending on surgeon preference. Once both surfaces have been prepared, the arthrodesis site is reduced and inspected. Adequate bone-to-bone contact is essential, and any residual osteophytes or irregularities should be removed. Particular attention should be paid to rotational alignment and overall finger axis. If necessary, fluoroscopy can be used to confirm both alignment and resection quality before fixation. For fixation, I prefer to use a cannulated headless compression screw. My preferred technique involves retrograde insertion of the guide wire through the distal phalanx. A small incision is made at the fingertip, allowing precise identification of the entry and exit points and facilitating a central trajectory through the distal phalanx. An alternative technique consists of antegrade guide wire placement, followed by advancement across the fusion site. Both methods are valid. However, in my experience, the retrograde technique avoids the need to cut or modify the guide wire and reduces the risk of bending the wire or creating a false track while advancing through the proximal fragment. Once the guide wire position has been confirmed fluoroscopically, the canal is prepared according to the implant system guidelines. Particular care should be taken when crossing the narrowest portions of the medullary canal to avoid cortical perforation or fracture. The headless compression screw is then inserted. In this case, a 2.6 mm Herbert-type screw was selected, which is generally appropriate for most index, middle, and ring fingers. In smaller digits, particularly the little finger, screws measuring 2.0 or 2.2 mm may be more suitable depending on the patient's anatomy. The headless compression screw is then inserted. In this case, a 2.6 mm Herbert-type screw was selected, which is generally appropriate for most index, middle, and ring fingers. In smaller digits, particularly the little finger, screws measuring 2.0 or 2.2 mm may be more suitable depending on the patient's anatomy. As the screw is advanced, adequate interfragmentary compression and final alignment are confirmed. The implant should be buried sufficiently beneath the bone surface to prevent prominence and minimize the risk of soft tissue irritation or nail bed complications. Once fixation is completed, the wound is closed using a single-layer tenodermodesis, repairing the extensor tendon and skin together. I typically use a 5-0 monofilament suture for skin closure. Postoperatively, a soft dressing or protective splint is applied, allowing early mobilization of the adjacent joints. Patients are instructed to avoid forceful gripping activities and heavy loading until radiographic evidence of fusion is achieved. Distal interphalangeal joint arthrodesis remains one of the most reliable procedures in hand surgery, providing predictable pain relief, excellent stability, and high patient satisfaction when appropriate alignment and compression are achieved.